Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you again for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast, we're talking with an expert on questions in cardiology. But before starting, for Australian audiences, listening does give you eligibility for your CPD, so log in and note this as an activity. You may also consider journaling, reflection and adding to the review and performance section in your CPD. Well, cardiovascular disease is a major cause of mortality in Australia, responsible for around 1 in 4, that's 24% of all deaths. On average, around 120 people in Australia die from cardiovascular disease each day, equivalent to one person every 12 minutes. And 40% more men die from cardiovascular disease compared to women. Well, with these statistics in mind, it's perhaps as well that the field of cardiology appears to be galloping toward the future with exciting treatments to manage this substantial burden of disease. We are witness to the development of incredible percutaneous interventions, including coronary stenting, valve replacements and repairs, watchman devices, radiofrequency ablations, as well as enhanced diagnostic tools and pharmacologic choices. At times, I've found the pace of change difficult to stay current with and was interested in putting some questions forth to my colleague Dr. James Sapontis to clarify my understanding and build my knowledge base. I was curious about the protocols around dual platelet therapy and their combination with DOACS, a combination I've observed leading to increased occult and overt gastrointestinal bleeding and the escalating use of iron infusions to direct deficiency states, as well as capsule studies to determining oozing sites within the GI tract. I was also interested in the indication for the use of mitraclips, the place of B-type Natriuretic peptide test in the elucidation of heart failure, as well as many more developments that have solidified their place in the clinical world of cardiology. So please join me with the ever-patient and erudite cardiologist James Sapontis as we explore these points in more detail. James Sapontis, cardiologist and a great friend. Thank you for coming back to Everyday Medicine and thank you for allowing me to pick your brains. So often I've done this. I would like to put some questions to you. They're not really things that are new in cardiology, but they're questions that have come into my head and I haven't completely understood this, and maybe other people will find some value in the questions that I'm going to put to you about, they're not really controversies, but about cardiology. The first one I would like to ask you, you can sort this out for me in my own head, dual platelet therapy, exactly how long should it be continued for? And I'm going to ask as a subsequent question, why do we continue aspirin, which is, in terms of the gastrointestinal tract, often nostrogenic, and not Plavix like clopidogrel type therapy, which doesn't tend to exacerbate the GI mucosa like aspirin does. Can you tackle those questions for me? How long and why one, not the other?
Hi, Luke. Thank you once again. It's always a pleasure to be back, and a very interesting question to start with, and a very reasonable question. And let me just preface this by saying it's a question we ask ourselves, actually, and what we debate about commonly within our own cardiological groups. To understand some of the answers behind that, you need to have a little bit of history behind stenting. And we go all the way back down to the 1980s, where we had the beginnings of bare metal stents and the Palmer-Schatz stent, which ironically used to come on rolls of stent, and you'd pull out a roll and cut the stent into certain lengths and crimp that onto a balloon and put that into a patient's artery. What we found back in those days is we actually used to put patients onto warfarin for those stents, more so than aspirin at all. But still found that some of those stents did have thrombogenic properties in those stents themselves. And over a period of time and investigations, we found that the majority of thrombosis within the coronary arterial system was due to platelet aggravation and the formation of fibrin itself, and activated platelets were the causes of the stent thrombosis, more so than the activation of the coagulation system.
Yes, right.
So moving forward to the modern day, we learned our lessons back in those times that antiplatelet therapy was the more important of the two. We started off with long-term antiplatelet therapy using aspirin, lifelong, on the premise that we wanted to avoid any possibility of stent thrombosis going forward. And when you treat enough patients with stents, you realize that there's certain groups of stent thrombosis that occurs. The first group is acute, within the hospital. The second group is subacute within, a few weeks or something of that nature. You can get stent thrombosis in the first 2 years, but additionally, you can actually get long-term stent thrombosis, particularly from anywhere between 5 and 6 years. And we also know that the reason for the stent thrombosis is, once again, platelet aggravation. So how does this all play, and how are things changed? Well, stenting technology has actually changed as well, and that puts a little bit of a spanner in the works, because the biggest cause for stent thrombosis in the past was a stent that was not pushed up against the wall of an artery and hadn't been covered by endothelium. And for the listeners out there, when you put a stent within the wall of an artery, after about 6 months, it's completely covered by new endothelium, and you cannot see the stent at all if you were to stand in that artery. So the concept of lifelong aspirin is to sort of say, well, back in the old days, we weren't 100% sure we got the stent wall, the stent against the wall of the artery.
Yes.
So to help prevent potential long-term stent thrombosis, stay on aspirin long-term. Additionally, you're a patient that has coronary artery disease, and there is some small benefit of aspirin long-term in those patients as well, over something such as warfarin, particularly when it comes to plaque rupture.
Yes.
So that's the first concept of long-term antiplatelet therapy.
Right.
Why do we now change our methods? Well, we know that you need to have dual antiplatelet therapy for a stent electively for 6 months and part of an ACS for 12 months. What happens to those patients that are currently on NOACs or DOACS or warfarin for atrial fibrillation? Originally, we actually used to give triple therapy, and the concept was that the dual antiplatelet therapy would work on the stent, and the NOAC would work on PE resolution or the atrial fibrillation or whatever it might be.
Yes.
Approximately 6 years ago, a trial came out called the WOERST trial, WOERST, and that randomized patients to triple therapy, meaning DOAC, aspirin, and an additional Plavix or whatever it might be, ticagrelor, versus those only taking a single antiplatelet agent and then a NOAC, and found that there was no difference between those two at 1 year for any stent thrombosis. So the concept is this: if you have a fresh stent within a coronary vessel, the NOAC theoretically will not prevent stent thrombosis. It needs platelet inhibition to prevent stent thrombosis, particularly in the first 6 months. So in the first 6 months, there are still stent struts open there and within the blood circulation. However, we know now that we probably don't need 2 antiplatelets plus a NOAC to stop the thrombosis. So the new guidelines recommend a single platelet agent in the first 6 months and the NOAC, and then going on to aspirin plus the NOAC long-term on the basis that there is still a small possibility for long-term stent thrombosis. The little caveat to this is that in the first 6 months, they recommend either Plavix or ticagrelor, as it has a higher anticoagulation effect than what aspirin does. And then after the 6 months, switching back to aspirin.
Yeah, so that less overall bleeding risk with aspirin versus ticagrelor or clopidogrel.
Yes.
I see.
So it's a little bit of a misnomer, because it's hard to experiment with these things. It's hard to sort of say to a group of patients, hey, listen, it's been 3 years since your stent, and we're going to put you in a group where you're not going to have any aspirin versus a group that does have aspirin, whereas historically we know that occasionally this potentially stent thrombosis can potentially come forward. And that's where it's going to be hard to determine whether we truly need aspirin long-term in patients that have had a stent. There are trials ongoing at this point in time to determine whether that's the case, but the trials always have a backdoor escape policy to them. And it's similar, I try to sort of relay this to other physicians. It's similar with understanding whether medications work on pregnant ladies. I mean, how are you going to find out whether a medication affects the fetus? I mean, it's a very hard thing to do.
Yes.
Because fundamentally it's unethical.
Yes.
And this is where we're having our problems to understand whether we truly can stop aspirin and just keep them on a NOAC after 2 years of having a stent in situ.
The NOAC in that instance, like, I'm just curious, why that we've got antiplatelets, okay, but the NOAC, we're not talking about atrial fibrillation here. What's the specific reason for the NOAC? You just need that extra anticoagulation.
So NOACs, I mean, in those patients, for example, that do have atrial fibrillation.
Okay, right. Yes.
Okay, and for example, have a stent. I had a patient today who has had his stent inserted about 4 years ago and has atrial fibrillation. I performed an angiogram because he was getting more chest pain. And it wasn't until after the angiogram that I realized he wasn't on aspirin or clopidogrel and hadn't been for the last 4 years.
Yes.
And I'm then thinking to myself, what's the reason why I'm putting this man on aspirin again? But if you look at guideline recommendations, yes, this is what they state. And those guidelines are made based on evidence that was recorded many years ago with different types of stents. So they haven't caught up with the new technology we have. But if you go by the book, by the guideline recommendations, an antiplatelet agent should be always present in someone that has received a coronary artery stent to some degree.
Yes. So until the guidelines change and we have further information, that's what we're going to follow. Thank you very much for bringing us up to speed on that. The brain natriuretic peptide BNP, something that we see ordered a lot in hospitals. I'm not sure if that's filtered down specifically into primary practice. Do you have any comments about that, ordering the BNP or the NT Pro BNP?
Yeah.
That maybe we're not quite sure. Do they have heart failure? Is it sort of venous sort of edema that's presenting with some leg swelling? Is it something that the GPs in primary care should be ordering, having the front of their mind? Yes, we're not sure if it's heart failure. We're listening, can't be sure clinically. We'll just order a BNP.
I think so. I mean, I have a love-hate relationship with BNP. I love it when it's normal. I don't like it when it's high. And the reason for that is, BNP originates from stretch receptors localized in the atrium. And one of the biggest issues you see in congestive cardiac failure is preload, an excessive amount of preload. And most of the diuretics we use in heart failure is aimed at reducing preload within the heart. But BNP is very useful in patients, particularly with a mixed diagnosis of something like shortness of breath. And, ankle edema itself, once again, I think, it's extremely common, and it can be common in patients that, for example, don't have heart failure and maybe have venous insufficiency or something of that nature.
Yeah.
But I like BNP in the syndrome X type patient, and the patient that comes in that isn't physically active, isn't obese, is obese, and might have type 2 diabetes, and on echocardiography has suggestions of heart failure with preserved ejection fraction or HFpEF, but it isn't very severe. And you want to know, is this person really just unfit? Are they do they have maybe some underlying respiratory disease, or is this all potentially related to the heart and could be effectively treated with diuretics?
Yes.
And that's the next component to it. So, sending off a BNP and seeing that it's, 450 is something below that is unlikely to be heart failure, but anything above 1,000 is more than likely to be heart failure. And then you have a good impetus to be confident that diuretics are going to be useful in this, and the patient's heart has an excessive amount of preload.
Yes.
So it's an excellent diagnostic tool. I would be careful about it, though, in the elderly. The elderly, particularly over the age of 85, they live a lot of their lives in constant chronic preload overload, and their BMPs will be elevated chronically, and trying to diurese them down to a normal BMP will result in a lot of other problems as well: hypotension, renal impairment, hyperuricemia. So it can be a little bit detrimental, particularly if a patient has multiple issues. For example, if they're currently undergoing therapy for cancer, they have underlying chronic renal impairment, they're on dialysis, BMP is not very useful in that aspect. It can be a little bit deterring in those situations. So it's quite useful, for example, in a patient that's never been diagnosed with heart failure before, has come in with mild ankle swelling, and the echocardiogram shows a normal LV function and a mildly dilated left atrium, where it's not quite obvious what's happening on the echo. A BMP is extremely useful.
Yes.
And would be used by most cardiologists. It's important that the GPs also know that there is a lot of times an out-of-pocket fee for the BMP. So it's not a good idea to potentially do serial BMPs consistently. Maybe just do one and then reassess the patient in relation to the response to symptoms themselves.
Yeah, and cardiac referral. SGLT2 inhibitors we've talked about a little bit before, but can you just refresh? They're being used, it seems, increasingly now by cardiologists for heart failure. Just a very quick précis about their mechanism and what their place of use might be.
So, this new SGLT2 inhibitor is commonly used obviously in diabetic control, and has been really the mainstay of a lot of heart failure therapies. And it's involved with the sodium glucose transport system. It is a tablet that is now mainstay therapy within heart failure with reduced ejection fraction, but also in patients with heart failure and preserved ejection fraction. And I also occasionally use it in patients, for example, with valvular dysfunction as well, that, for example, have enlarged left atriums and some mild symptoms of something like, for example, mitral regurgitation. It is quite important in these areas, and in trials have shown improvement in symptoms in those patients. The question is, which patients do you use it in HFpEF and which ones don't you? You have to be confident that you have diagnosed the HFpEF rather than it being just a mild case of a mildly enlarged left atrium. So use it in those patients where you're confident that the HFpEF is quite pronounced, or it's been diagnosed by another cardiologist as well. And additionally, if you have a patient with an EF of below 40% or 40% and below, usually patients like that need to be on drugs like Entresto, and the second line therapy is definitely your SGLT2 inhibitors as well.
Perfect. Thanks for clearing that up, James. And then mitraclips. We talked about the mitraclips pump previously. Mitraclips, every now and then I have a patient that comes in with mitraclips and think, oh, here's another procedure that is doing that's a bit sexy. Seems to be phenomenal in the outcome, and it's again kind of relatively. I guess I'm not sure if we can say it's non-invasive, but it's relatively non-invasive, certainly less than open heart surgery. Just take us through that. What's it for exactly, and very quickly how it's done.
Yeah, I'm sure everybody out in the community, as practitioners, as physicians, see a lot of mitral regurgitation. It's pretty much expected to some degree in every echocardiogram that you actually order. Mild mitral regurgitation here, there, and everywhere. What people may not probably understand is the mitral valve is quite a complex valve. It's not like the aortic valve. You have three, triangular leaflets opening and closing. The mitral valve itself is almost like a pair of curtains, and looks like a fish's mouth, and really opens and closes, and has strings like a parachute that go into the ventricle that prevent it from letting blood back into the left atrium, and it sort of parachutes out. when this valve becomes incompetent, it can be due to a numerous number of factors. And this is what makes mitral valve disease a little bit complicated. You can have problems where those little parachute strings break, and then subsequently the parachute sort of flutters in the wind, and that allows blood back into the left atrium. You can have times where the apparatus itself builds up proteoglycans, making it quite spongy and not as billowy when it actually fills with blood, and subsequently that can allow blood back into the left atrium. And you can have the deposition of scar tissue and calcification for things like rheumatic heart disease, which makes it also incompetent. The concept of all of this was that there's also general wear and tear mitral regurgitation that occurs over time. And this is the most common cause of mitral regurgitation. Unfortunately, this happens later on in life, or for example, in your mid-80s or your late 80s, or even potentially in your early 90s. So what happens with all these patients that are slowly having this mitral valve become worse and worse over years and years and years? And what they discovered is those patients generally have a loose valve leaflet that can flutter in the wind, that only needs to be sort of stitched down. And that's where the mitral clip has come into play. Okay, now I've obviously very generalized all of these sort of things so people can imagine them, but the concept actually comes from a thing called an Alfieri stitch. And it was an Italian cardiothoracic surgeon that would go in and, for example, perform coronary artery bypass grafting and then simply put a stitch in the center of the mitral valves themselves. And by putting that stitch in that mitral valve, it allowed less blood into the left atrium.
Right.
And that's the concept of a mitral valve clip, is that it's a little small clip that looks almost like a paper clip. It's probably the size of a 10-cent piece, maybe a bit smaller. And what it does is it enters through the right venous pathway into the right atrium, subsequently crossing the left atrium using a septal puncture technique. And then you have a steerable catheter that you're able to manipulate through the mitral valve. And what you're trying to do is, with a V-shaped clip, is trying to catch the leaflet of the mitral valve that is untethered or flail, for lack of a better word. And it takes a little bit of skill because you have to line it up perfectly.
Sounds very hard.
Yeah, well, line it up perfectly and clip this flail segment closed. And once you can get that closed, the mitral regurgitation decreases in severity.
Right.
Subsequently, you pull everything out, the septal puncture heals, the groin is healed.
Right.
When you look at trials like the COAP trial, you can see that patients that have had 3 severe mitral regurgitation with these flail segments and having this clip perform successful, you have improvement in rehospitalization, improvement in BNP levels, improvement in mortality, and patients' quality of life improves as well. So there is good evidence that this thing can work. Key to it is actually the mitral valve. You can't put this clip in for rheumatic heart disease. You can't put it in, for example, if the clip is very flail, you'd need 3 or 4 clips to have a complete prolapse. If, for example, those chordae tendineae are snapped, the clip may not be ideal in those situations. So it is very useful, excellent for those patients that aren't suitable for surgery, shown to have a mortality benefit, but it has to be correlated with the appropriate mitral valve disease for it to be truly successful.
And careful selection of patients. And do they need to be anticoagulated because it's an artificial device long term?
No, they don't. They're generally placed on aspirin, but most of these patients have atrial fibrillation as well. So,
no, okay.
Yeah, I think there is a short period of anticoagulation, but then afterwards they can stop, I believe.
James, that has answered some queries in my mind, and I think a lot of people's, and really appreciate you running us through that so eruditely. I really appreciate it, James, as always. Thank you for being so available and for providing such an amazing service to the population in the southeastern part of Melbourne. We really appreciate it, and your expertise, James. So take care. Thank you so much. Thank you.
Thanks, Luke. Anytime.
I'd like to thank you for joining me in the conversation with the ever-patient and extremely knowledgeable James Sapontis on questions in cardiology. He's cleared up a lot of points that I had questions about, and I hope you found this discussion interesting. And next week we have another interesting guest, and during the podcast series we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only and reflect the opinions of the guests being interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@geohealth.com.au.